Hello everyone, welcome back to another session in dentistry and more. Today we have the continuation of our maxillary nerve blocks. So last session was about intraorbital nerve block. So this session is posterior superior alveolar nerve block, or also known as PSA. So we'll start with nerve anatomy. That is the tritaminal nerve, which has got three parts: ophthalmic, maxillary and mandibular. And this posterior superior alveolar nerve is a part of maxillary nerve. So this is a maxillary nerve. So you can see all the branches. So last session we finished our intraorbital nerve, which has got terminal branches like inferior palpebral, lateral nasal and superior labial. And you can see the anterior superior alveolar nerve, then the middle superior alveolar nerve, and you can see the posterior superior alveolar nerve, which is originating just below the intraorbital foramen. So when we apply intraorbital nerve block, it mostly anesthetized these parts, that is palpebral, that is the terminal branches, palpebral, nasal, labial, then the anterior superior alveolar nerve and middle superior alveolar nerve. Okay, so we have 1, 2, 3, that is the central incisor canine and the lateral incisor, which is supplied by anterior superior alveolar nerve, whereas premolars 4, 5 and the mesiobuccal root of 6 supplied by middle superior alveolar nerve, and the other molars, that is 7 and 8, that is second molar and third molar, also the roots, which is except, that is the distobuccal and palatal root of 6, that is the first molar, supplied by posterior superior alveolar nerve. Okay, now so this is how the nerve supplies the teeth, pulp and periodontium. Central lateral canine is supplied by anterior superior alveolar nerve, which is the anterior most branch. Then the middle superior alveolar nerve, which is supplying 2 premolars, and the mesiobuccal, which is near to the premolar, mesiobuccal root of first molar. The remaining, that is second and third molar, along with the other roots other than mesiobuccal, that is the distobuccal and palatal roots. Moving on, posterior superior alveolar nerve, which is a very commonly used nerve block technique for the maxillary posterior teeth, commonly the second and third molars. The first molar, mesiobuccal, is supplied by the middle superior alveolar nerve. So the distobuccal and palatal side will be supplied by PSA. So around 20 to 30% of cases, the mesiobuccal root will not be anesthetized when we give PSA. So in those cases we might need to give middle superior alveolar block separately. So that is about the nerve blocks, posterior superior and the middle superior alveolar nerve. The main thing is we need to visualize the skull size. The skull size is a very important factor with respect to the depth of soft tissue penetration. Okay, so always when we give PSA we use shorter needles because of this, to avoid these kind of complications. So the average depth of soft tissue penetration is 16 mm. So it can be used for the posterior superior alveolar nerve. The 16 mm will be the ideal depth of penetration with respect to the PSA. So it has got some other names such as zygomatic block or the tuberosity block, because it is being given in that area, zygomatic bone or maxillary tuberosity. So the nerve anesthetized is the posterior superior alveolar nerve and its branches. So the area anesthetized is mainly the parts of maxillary third and second molar and the first molar also, but except the mesiobuccal root, but only in around 20 to 30% of the cases. So that is the nerve and area anesthetized. Now what are the indications? Indications, as we discussed, when the treatment involving 2 or more maxillary molars, when supraperiosteal injection is contraindicated because of any infection or inflammation, or the supraperiosteal injection is found to be ineffective, in all those cases we can go for a PSA block. Whereas it is contraindicated when the risk of hemorrhage is too great. Okay, if the patient is hemophilic, in which case we can go for a supraperiosteal injection or a periodontal ligament injection. We should not go for a PSA nerve block in case of hemophilic patients because high chances of hemorrhage. So in those cases we can give just a PDL injection or a supraperiosteal injection instead of a nerve block. So what are the advantages? The foremost advantage is it's very atraumatic and there is high success rate. So advantage is just we are not getting any bony resistance, so it's just piercing through the soft tissues. The patient also won't feel much pain, so that is why it is the most atraumatic, one of the most atraumatic injection. Then high success rate around 95%, and we need just one injection compared to 3 infiltrations, and it minimizes the total volume of local anesthetic solution administered because we are giving only once instead of 3 infiltrations. But the disadvantages are the hematoma, that is the most commonly reported problem associated with PSA, and this technique is somewhat arbitrary, and sometimes second injection necessary for the treatment of the mesiobuccal root of maxillary first molar in around 20 to 30% cases, but otherwise it is just one injection is fine if it is second molar or third molar. But in case of first molar where the mesiobuccal root is involved, we need to give a second injection. Now the technique of PSA, that is 25 gauge short needle is used. In intraorbital we were using long needle. This is short needle in order to avoid all the complications. So insert needle at the height of mucobuccal fold above the maxillary second molar, as you see the picture here, mucobuccal fold of maxillary second molar. So the target area is the PSA nerve, which is posterior, superior and medial to the posterior border of the maxilla. Posterior, superior and medial to the posterior border of maxilla. So this is the target area where the PSA nerve lies. So the landmarks, the mucobuccal fold, maxillary tuberosity and zygomatic process of maxilla. They are the landmarks. Okay, so landmarks are mucobuccal fold, maxillary tuberosity and zygomatic process of maxilla. And we should have the patient open their mouth only halfway, not completely, because it creates more room for the injection. Then retract the patient's cheek with mirror, pull the tissues at the injection site very taut, then orient the bevel towards the bone, insert the needle at height of the mucobuccal fold over the second maxillary molar, advance the needle upward, inward and backward. Okay, upward, inward and backward direction. So patient or the dentist might not feel the resistance, and penetrating to an average depth of 16 millimeter is adequate, and aspirate in two planes by rotating the bevel 1/4 turn. Okay, 1/4 turn we need to rotate and aspirate in two planes, and deposit around 1 to 1.5 ml of solution and wait for 3 to 5 minutes. So always we need to be careful that we need to advance the needle in one moment. Okay, not three separate movements, just one moment we need to make all the directions, not three separate movements we should not create, because it will create a traumatic feeling, because usually this is very traumatic. So that we need to be careful, only one movement for the injection, not three separate movements. Okay, that is, we are going to do a upward, inward and backward direction, so that should be done in a one movement. And for left PSA, the dentist should be at 10 o'clock position, and for the right PSA, the dentist should be at 8 o'clock position. So the signs and symptoms, subjective signs, there will be absence of pain. There will not be much subjective symptoms, because patients will not be having any sensation on the buccal mucosa or lip. So the lack of pain during instrumentation can be an indication for the LA effectiveness. So also we can use in electric pulp testing, unlike other nerve blocks, because in any other nerve blocks such as the intraorbital, IA and B, all nerve blocks gives very subjective symptoms. Subjective symptoms, that is, patient gives you some clue about the LA effectiveness. Patient says the numbness, tingling of lip. In PSA, the subjective symptoms are very minimal, so the dentist can do instrumentations and make sure that the LA has worked out, or we can use a electric pulp testing to check the LA effectiveness. So the safety features, we should give slow injection, and there is no anatomic safety features to prevent over insertion of the needle, so we need to be very careful about the length of the needle. Okay, slow injection and length. So the dentist should be careful about the length, because there is no anatomic landmarks. So the depth of the needle penetration should be correct. Over insertion increases the risk of hematoma, and too shallow might still provide adequate anesthesia. So always be very careful about the over insertion. So what are the reasons for failure of anesthesia? One thing is, needle is too lateral. Okay, so we need to redirect the tip medially when it is going too lateral, or the needle is too posterior. We can withdraw the needle to the proper depth, or needle not high enough, so we can also redirect the needle tip superiorly. So it should be medial, superior and posterior, but it should be at a proper direction. It should not be too lateral, should not be too posterior, and should not be needle not high enough. Now the complications, that is very important in PSA, very commonly asked question. What are the complications? We already discussed a bit. One thing is the hematoma. this is commonly produced by inserting the needle too far posteriorly into the pterygoid plexus of vein. So there is presence of pterygoid plexus of veins. If you miss out this point, you won't get any marks. So never miss this point. Pterygoid plexus of vein, that is present posteriorly. Okay, when we are going too far posteriorly, we are going to inject the solution into this part, that is the pterygoid plexus of veins. It creates hematoma. And also there are problems of mandibular anesthesia. Since we are giving maxillary anesthesia, it should not create unnecessary mandibular anesthesia. Why this is happening? Because the mandibular division of the fifth cranial nerve, okay, that is the trigeminal nerve, is located lateral to this PSA. It is located lateral to this PSA. So if we are giving LA lateral to the desired location, what happens is going to deposit solution on the mandibular division of the cranial nerve. Okay, instead of maxillary, we are going to anesthetize mandibular nerve because we are giving too laterally. So that is the second problem. First one is hematoma, then the mandibular anesthesia. The next thing is diplopia, that is the double vision. Diplopia. How this diplopia is happening? So when we are giving PSA, when they are being deposited near the pterygomaxillary fissure, okay, pterygomaxillary fissure, they are the areas, or they are the structures or the fissure which is present near the PSA, just like our pterygoid plexus of veins. So when we are depositing the solution near the pterygomaxillary fissure, it causes diplopia of the ipsilateral eye, or the left or right, wherever the injection is being done, diplopia will result. Not in all cases, some around 30 to 40% of the cases. This is because the local anesthesia diffusing superiorly and medially to anesthetize the orbital nerves. It will affect the orbital nerves. It is only affecting ipsilateral, not bilateral, only on the injection site. Okay, so this is going to affect the orbital nerve. Next one is a facial nerve. Facial nerve paralysis. So facial nerve paralysis, it's because this local anesthetic injection is going into the posterior superior alveolar artery. So when it is being injected into this artery and it is going subsequently to the petrosal artery branches, and finally it creates facial nerve palsy. Or some authors says that the improper placement of the needle could lead to the damage of pterygoid plexus. So this local anesthetic will reach the inferior portion of the parotid gland, which anesthetize the cervicofacial division of the facial nerve, or medial pterygoid muscles, which would result in trismus. So PSA has many side effects or complications such as hematoma, mandibular anesthesia, diplopia, facial nerve paralysis and trismus. So you need to explain how it is happening. In hematoma, it is associated with pterygoid plexus of veins, mandibular anesthesia because when it is being injected lateral, that is mandibular nerve, and diplopia, it is associated with pterygomaxillary fissure and orbital nerves, and facial nerve paralysis, it is associated with either sometimes it could be the middle meningeal artery and petrosal artery branches to the facial nerve injury, or it could be due to the solution being placed through pterygoid plexus into the parotid gland, inferior portion of the parotid gland, where the cervicofacial division of the facial nerve is there. That is how it is creating a facial nerve paralysis, and it is affecting the pterygoid muscles, that is the medial pterygoid. It results in trismus. So it is a very commonly asked essay question, and there will be definitely an associated complication part regarding the. So this is the nerve block which is associated with most number of complications. So that was all about PSA. So PSA, just like any nerve block, when you are writing for exam, you need to write about the landmarks, nerve anesthetized, the area anesthetized, indications, contraindication, its advantages, disadvantages, and little bit about its beginning part, that is the maxillary, it is coming from the trigeminal nerve, and all those things, along with the complications, okay, why it is being failure, and also the technique. Okay, so this is the most important part in posterior superior alveolar nerve. So I'll come up with a new topic in oral surgery. Thank you.